Great. Well, I wanted to thank everyone here for inviting me to come speak to you. I want to thank Kathy personally for inviting me here. I still remember being a resident here at Texas Heart and setting up the cardiac operating room and handing Kathy, when she was a student, 2 bottles of Amicar so she could prime the pump. But it's always great to be back. So I have no disclosures or no financial relationships with any commercial interests. And work on these projects that I'm going to present to you is supported by a couple research foundations and the NHLBI and the Additional Single Venture Research Fund. And so I don't know if this video will play, it doesn't have to.
Shall we play a game?
I wanted to start today by getting everyone in the room thinking about data. So data surrounds us. Does anybody know what movie this is from? Just shout it out. War games. So, a lot of the older, more wise people in the audience recognize this movie as War Games. It was a movie from 1983. And so this was an American Cold War science fiction film directed by John Badham. It follows Matthew Broderick. He's a hacker who hacks into a US military supercomputer that was programmed to predict possible outcomes of nuclear war. And so he then discovers the work of an artificial intelligence researcher and then runs a nuclear war simulation and attempts to start World War III. So I won't spoil the end for you. But incidentally, in 1983 was when Norwood first wrote about his first case report of the Norwood operation. And so when we think about this, I took out the interactive polling for time, but I just want you to take a second and think about what post-operative day do you think the first Norwood was discharged from Boston Children's Hospital? So do you think the patient didn't survive? Just raise your hand when I read the answer that you think it is. So did the patient not survive? Between 1 and 14 days, 15 and 29 days, 30 to 60 days? I see some hands here. 60 to 120 days, greater than 120 days, or patient was kept in the hospital. Okay, so some for that. And so when we look at the case report, the patient was actually released from the hospital on the 18th post-operative day, which was kind of a surprise to me. But then let's look at more modern data. So if we look across the street, on what average post-operative day is a patient after the Norwood procedure discharged at Texas Children's Hospital? So same answers, just raise your hand when you think you don't know the answer. 1 to 14 days, a couple of hands there. 15 to 29 days, 30 to 60 days, 60 to 90 days, and then greater than 120 days. So some hands there too as well. So when we look at the data between 2015 and 2018, there were 66 patients who had a Norwood operation, and there was 58 of them survived. So that was an 88% survival rate. And the median length of stay was actually 94 days with kind of a wide confidence interval. And so I just wanted to get us starting with it, or get us thinking at the start of this presentation that data surrounds us in many different ways. And it's kind of awe-inspiring and surprising how much data we interact with every day, in our daily lives and when we work in the hospital. And so when we think about the perioperative environment, there's a lot of data that we interface with. And so the old dinosaurs in the room will talk about things you can touch, feel, sense, see. And but in the various areas, there's a lot of data that we can use and capitalize upon so that we can take better care of our patients. And so Charles Friedman from Michigan wrote about the fundamental theory of informatics in 2009. And what he basically says is a human brain in conjunction with data or computers should function better than a human by itself without any computational technologies. And so for us that take care of patients with congenital heart disease, I think we all know that our patients are are at high risk for morbidity and mortality. So this is data out of Stanford where they looked at the pediatric perioperative cardiac arrest registry. And what they found were that children with heart disease were sicker compared to patients without heart disease at the time of anesthetics. And an important point of this research was that the cardiac arrests occurred outside of the cardiac operating room. So that Fontan patient getting their teeth cleaned, or the Glenn getting a tonsillectomy. And then here it is. It says these cardiac arrests were frequently occurring outside of the cardiac operating room, in the general operating room, and were likely to be from cardiovascular causes. So this is kind of their breakdown of the data and the causes of cardiac arrest when they looked at this registry. And so the question I have is, can we actually use data in more innovative ways so that we can take better care of these high-risk patients? And so the outline of today will be to look at some of the outcomes in hypoplastic left heart syndrome, some of the limitations in ECG monitoring and benefits of computational signal processing, and the single ventricle pre-arrest state, and how can we better quantify this. We'll then look at a little bit at computer learning and advanced monitoring systems, predicting arrests in single ventricles, and real-time autoregulation monitoring strategies. And so there were a couple of questions yesterday about hypoplas, so I elected to leave these slides in. It occurs in about 2 to 3% of all congenital heart disease. And then here we trace the pattern of blood flow through the heart. There's an underdeveloped left ventricle, and then the oxygenated blood is in the left atrium, passes through an atrial communication to the right atrium, where it mixes with deoxygenated blood from the superior and inferior vena cava. The blood then travels to the right ventricle, then to the pulmonary arteries, where it can go to the pulmonary or to the lungs for oxygenation, or across the ductus arteriosus for systemic perfusion. Let me show that. The mortality in this patient population was essentially certain until the development of the Norwood procedure in 1983. And this is the Norwood operation done in the first couple of weeks of life. A neo-aorta is created to allow the right ventricle to support systemic circulation, and a Blalock-Tossic Thomas shunt is created to provide pulmonary blood flow. And just to complete the palliation pathway, a couple months in, the Glenn operation is done, where there's a cable pulmonary connection from the superior vena cava to the pulmonary artery, and the BT shunt is removed. And then finally, the Fontaine is performed, where there's a cable pulmonary connection from the inferior cava to the pulmonary artery. And so essentially, these are very high-risk patients. The interstage mortality for hypoplas in the single ventricle reconstruction trial was described to be at around 12%. When we look at Texas Children's Hospital discharge mortality rates from 2010 to 2014, it was on par about 12.3%. And from the single ventricle reconstruction trial data, mortality risk is highest prior to stage 2 palliation. So of the patients that passed away, 87% of them passed away between that Norwood and Glenn operation. And so one of the reasons why is that there's vulnerable coronary blood flow. So here's the coronary artery. And then as you remember from our previous drawing, blood flow has to travel up the ductus arteriosus and retrograde to perfuse the heart. Even after the Norwood operation with the BT shunt, there's diastolic runoff, which can cause diastolic hypotension, creating vulnerable coronary blood flow. And so what we did was we looked at ECG instability metrics at Texas Children's, and what we saw was there was no difference in the pre-arrest state versus our control patients when you look at their ST segment. And so when you, in whatever lead you look in, there wasn't really a distinguishing factor of the ST segments. However, with some signal processing, we created some three-dimensional visualizations of ECG metrics. Let's see if this will play. So this is a time-lapse video of the ECG instability over the study period of the 4 hours after a Norwood operation. On the left, you see a patient that does not have cardiopulmonary arrest, and on the right, you see a patient that's approaching cardiopulmonary arrest and is deteriorating. And even with your naked eye, you can see that there's a lot of movement in this ST segment, which we believe is a predictive factor for cardiopulmonary arrest. So when we look globally at the data, you can see that there is a better you can use this metric to distinguish a pre-arrest state versus a control state of a patient that's doing well. And so there was a 60% increase in that vector magnitude and instability prior to deterioration with a p-value of less than 0.02. We then took this ECG instability metric and looked at coronary perfusion pressure. So on the y-axis here, you see that in ECG instability metric, and on the x-axis, you see bins of coronary perfusion pressure. And what we can see here is that there is increased ST segment instability at both elevated and low coronary perfusion pressure. So that makes intuitive sense. If you have low coronary perfusion pressure, you're making the heart ischemic, and there's increased ECG instability. And so an optimal coronary perfusion pressure based on this data is about 28 millimeters of mercury. And so let's move into some computational methods for predictive modeling. So this is the SIGBAY platform. It was developed by Craig Russin, and it is a platform that continuously collects high resolution physiological data. And so all of these data elements are collected and stored in a database that can be harvested and research can be done with it. This was activated on January 1st, 2013 at Texas Children's, and collects about 200 to 250 megabytes per day per bed space. And this is about greater than 80 terabytes of data on over 1 million patients. And so when you do the math, this is probably more closer to 15 million hours of patient data now. And so now that we have all this data saved, we can now play with it. So there's a lot of different ways you can do this, but one way is to take the historical source data and then take about 80% of it to use to train your model, and then 20% of it to test your model. With the training data, you can apply various machine learning models and then weigh those different data elements to try to create predicted outcomes and use your model then to test your model with the 20% of data and see how well it performs. There are a wide variety of machine learning algorithms, and more so that we can even talk about today. But a very simple one is a logistic regression model. So in a logistic regression model, there are two states, the state on the left and the state on the right. And then you can basically feed the model different data elements and see how well it performs and can predict the two different states. So what if on the left, we put a baby or a single ventricle patient that doesn't have cardiac arrest, and on the right, we put a patient that is about to have cardiac arrest. And now we have all the data elements and how well can our model perform. So that's essentially what we did. We took data from Texas Children's and created a model to predict cardiac arrest using real-time data. The model was a multivariate logistic regression model, and it had 6 variables that fed into the model. One of them was the ST ECG instability metric that I showed you earlier. And so the model looks at our heart rate, respiratory rate variability, the baseline ST segment, pulse ox, and then the ST segment or ECG variability or instability metrics. When we looked at our model, we had 2 patient populations. In the blue is the patients that did not have cardiac arrest, so that's our control patients. And on the red bars are the patient population that had a pre-deterioration or pre-cardiopulmonary arrest state. And when we looked at this model, it had an area under the receiver operating characteristic curve of 0.91, indicating that it's a very good model. And this was able to predict cardiac arrest 1 to 2 hours in advance. We then wanted to look at the performance of our model over time. So we took we basically marched back in time from the events of cardiopulmonary arrest and looked at the receiver operating characteristic of the model as it gets further from the arrest. So you can see at time point 0 here is when the patient arrested. And then when we marched back in 1 hour beforehand, it had a ROC area under the curve of greater than 0.9. And then as we get further and further back, the model deteriorates, which is as expected. But the important thing here is that the earliest forecasting can occur between 4 to 5 hours. That's 4 to 5 hours that the perioperative care team can intervene on the patient, maybe escalate from step down to ICU level of care, change your vasoactive management, transfuse blood, or maybe even go back to the operating room. We then took the segments of time and created a relative risk index. So we basically compared the 1 to 2 hours prior to cardiopulmonary arrest with our entire patient population. And we were able to create a real-time risk index of the one particular patient prior to cardiopulmonary arrest. And what we find is that the risk begins increasing about 1.25 hours prior to arrest. And so here I show you 2 vital sign screens of 2 hypoplast patients. And this is what we see when we walk up to the bedside. But with advanced monitoring, it can actually provide a real-time risk indicator. So the patient on the left is about one-fold risk of having cardiopulmonary arrest. So this patient doesn't have risk of arrest in the next couple hours. But the patient on the right actually has a 3-fold increased risk of having an impending cardiopulmonary arrest. And so when you create models, it's important to test the model to see how well it does. So this is prospective testing. And this was done validating our algorithm in predicting cardiopulmonary arrest. And what we found was the receiver operating characteristic area under the curve was 0.96, indicating a very good model in 238 patients tested prospectively at Texas Children's Hospital. So this is the data from one center. So this is 238 patients, and there were 112 decompensation events. But we want to make sure that this data and this model is translatable to other hospitals. So this is now a multi-center study being where the model is being validated across 4 different hospitals. And it's not yet published, but I can tell you that the preliminary results are very promising. But what about cerebral autoregulation? So a topic near and dear to Ken and Kathy's heart. So I wanted to throw in a little bit about that. So just as a review of what Ken spoke to you about yesterday, autoregulation is maintenance of constant cerebral blood flow. And there are various mechanisms of this. The one that we mainly focus on in the lab is pressure autoregulation. And outside of these limits of autoregulation, the cerebral blood flow is passively dependent on cerebral perfusion pressure. So in those red areas is where you don't want to be. But the issue is that the limits of autoregulation are quite variable among individuals. This is an adult study of cardiopulmonary bypass cases, and you can see that the lower limit of autoregulation is quite variable. So in this particular study, it was 66, but there was an interquartile range of 43 to 90 millimeters of mercury. Autoregulation can be measured using the pressure reactivity index, as Ken showed yesterday. And then this is just a brief review of what he talked about. With these PRX graphs, you can actually delineate when autoregulation is intact, where the PRX values are negative, and when it's impaired, when the PRX values are positive. Then Ken and Kathy did the important experiment where cerebral autoregulation could be measured non-invasive using near-infrared spectroscopy placed on the head. And so you can use the same correlation techniques. But I'm going to take a moment here and pause and ask, does intraoperative management matter? And I would say, personally, we feel that yes, it does. So for congenital heart surgery, mortality rates are not good enough anymore. So what we care about are the neurodevelopmental outcomes. And there are many things that can play into a child's or an infant's neurodevelopmental outcome based on what happens in the operating room. So one thing that we can take care of as perfusionists and cardiac anesthesiologists is blood pressure management. And so when the blood pressure is too low, then you'll have ischemic events in the head. And then when it's too high, you'll have intraventricular hemorrhage. So this is that same concept presented in a different way. And what this group of authors are asking is, what is the lower limit and the plateau range of cerebral autoregulation? And can there be a precision medicine approach to determine that lower limit of autoregulation? And so to that, I would say, yes, we can do that. And so this is data from Texas Children's Hospital of all neonates from 2013 to 2018. And we basically wanted to see, can we delineate the lower limits of autoregulation? And to do this, you just need two signals, the arterial blood pressure and then the NIRS. From this, we had 169 patients, and this was our patient demographic. And essentially, I calculated the cerebral autoregulation curves for all of these patients using MATLAB programming, and then this is our data. So these are the same plots that Ken showed you yesterday, but this is of all neonates at TCH from that time period. And then on the x-axis, you'll see the blood pressure. On the y-axis, you'll see the HVX, which is that indice of autoregulation. Remember that positive values are bad, indicating that you're not autoregulating, and negative values are good, meaning that you're on that plateau region of the autoregulation curve. We're going to pan out here, and then you'll see in that axis going backwards is age in terms of days. And so in these several hundred patients, I'm going to kind of spin the graph around so that we can see the blood pressure management should be in those light blue areas. And where you don't want to be is in those red areas. And then that indicates that you're below that lower level of autoregulation. And what we were interested to see is, one, can we actually write algorithms to manually do this, or actually automatically do this, I'm sorry, so that a human doesn't have to go in and actually put the sensors on the head and write the programming on a one-by-one basis. And two, what is that lower limit of autoregulation as you progress in days of life? So what we found were that the lower limit of autoregulation increases from 29 to 40 based on day of life 0 to 30. And then each day of life increased or corresponded to a 0.32 millimeter of mercury increase in that lower limit of autoregulation. An important point to take into this is that although there is a trend in an increase of that lower limit of autoregulation, there is a large amount of variance in the data. So I think that a personalized approach to autoregulation is necessary and indicated. When we look at the same data and we look at how poorly we did in terms of how much time we spent below that lower limit of autoregulation, we actually see that about 17% of our patients, or 17% of the time in the operating room, was below that lower limit of autoregulation. And then when we look at the severity of that time below lower limit of autoregulation, where you multiply how far below you were by the amount of time in seconds, we actually find that we did worse in patients that were less than 15 days of age, which is not unsurprising, knowing that it's difficult to predict what that blood pressure management and blood pressure targets should be, both on bypass and pre and post bypass. And so I'm going to end by pointing out that a real-time monitor of autoregulation is important, and this is what we've programmed in the sickbay interface. And so I designed this interface, and so the input signals to create this monitor are arterial blood pressure signal and the NIRS. And you'll see on the x-axis is the time. So this is a 6-hour window. And on the right side, you'll see that it's indicating in this particular patient that the blood pressure should be above a MAP of 52. And then the upper limit of autoregulation is 95. So you want to stay between 52 and 95. And then the real-time blood pressure here is 40. So there's a little caution sign indicating that you're below the lower limit of autoregulation. And so the goal of this monitor is to provide the clinical team a real-time understanding of the limits of autoregulation for targeted blood pressure management. And then this is a video. Okay, so great, it's playing. So this is a real-time video of a patient. I turned on the monitor as they were coming off bypass. I think this is a TET repair. But you can see here that the monitor or the algorithm has delineated a lower limit of autoregulation of 50, and the team is below it. And so now they are above, and then the current map is in the 50s. So in summary, what we did today was review the single ventricle pathway and then pointed out that the mortality is highest in the first interstage. With more advanced monitoring, we can actually hopefully provide better clinical care and clinical outcomes. And then we presented a data model for real-time analytics for the prediction of cardiopulmonary arrest in this population. And then I couldn't leave without talking a little bit about autoregulation in congenital heart surgery. And then so these are all the people that have helped me. Any questions? Thank you.